Hello, everyone, and welcome to our webinar, Value-Based Payment, What Have We Learned and Where Are We Headed? My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. Today's webinar will give us a bird's eye view on value-based payments. I would like to mention a few logistical items. You'll be able to download a copy of today's presentation from the CAQH.org website tomorrow. To clarify, the slides are not available right now, but you will be able to download them tomorrow. Also, a copy of the slides and the webinar recording will be emailed to you in the next day or so. We will save time at the end of today's program to respond to your questions. I encourage you to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. This webinar is part of our series on the topic of value-based payments. I'd like to thank our featured speaker for joining us today, Aparna Higgins, President of Ananya Health Solutions. Today, we will start out with an overview of CAQH Core's work on VBP. We will then move on to our featured speaker, who will walk us through the topic of VBP at a very high level. So let's get started with our first presenter, CAQH Core Director, Erin Weber. Erin?
Thanks, Jessica, and thanks to everyone for joining us today. Before we get into the meat of the presentation, I wanted to quickly give an update on the work that CAQH Core is doing in the value-based payment space. And before I get too far into that, just a reminder for those that may be new to the organization on the webinar today. CAQH Core is a collaboration of health plans, providers, vendors, clearinghouses that have come together to streamline administrative data exchange through industry collaboration. We really see our role as a facilitator of information, and we're designated by the Secretary of Health and Human Services as the national author for operating rules that were mandated in the Affordable Care Act. We are governed by a multi-stakeholder board, and we really see our role as not just developing operating rules, but also offering certification, building industry awareness on key topics, providing technical assistance, and promoting adoption. So really the full life cycle of the operating rule process. On slide 7, just to highlight the breadth of the work that CAQH Core has done to date, we have about 130 organizations that participate with Core to identify and develop industry solutions to streamline data exchange. We have developed to date 4 phases of operating rules for industry implementation, addressing key transactions like claims, eligibility, EFT, and ERA. 3 of those phases of operating rules are federally mandated. Then within our certification process, we have awarded, I believe the number today is 332 certifications to entities that had demonstrated their compliance with phase of the operating rules. So we've been working in this space of trying to help the industry come to a more uniform approach of information exchange. And as the CAQH Core board looked to the future, they really saw a need and an opportunity for Core to help streamline VBP operations. There are a lot of different models out there and a lot of different organizations trying to solve the volume to value conundrum. And as they're doing this in different ways. So based on CAQH Core's experience in bringing the industry together to streamline efforts, by collaborating now and applying some of the lessons we've learned in the past, our hope is to energize an effort to help this shift to value-based payments continue unimpeded by administrative hassles. Next slide highlights some of our work in this area to date. We have been doing this webinar series now since the middle of last year. We've had over 700 attendees, and we plan to continue this series throughout 2018. Our next webinar is actually on April 10th with Dr. Sue Turney, who is the CEO of Marshfield Clinic Health Systems, and she and I will be talking about some of the research that Core has conducted over the past 2 years to understand some of these operational opportunities within the value-based implementation space. And that report itself will be released at the end of the month. In addition to kind of the education series and the report, once the report is out, we will be launching an advisory group of a select group of multi-stakeholder representatives who will be charged with prioritizing and advancing some of the recommendations in the report that really align with our mission. So next slide, I want to talk a little bit more in detail about the report itself. The whole premise of the report is that, VBP is really dependent upon smooth and reliable business interactions between the various stakeholders, and establishing some consistent expectations and rules of the road in certain opportunity areas is really essential, because based on the research that we did, and that was through interviews with key stakeholders, surveys, literature reviews, it's really clear that non-uniformity is currently the norm when it comes to VBP operations. So the report outlines 5 opportunity areas. Within each opportunity area, there are sets of recommendations. And interestingly, the report also includes candidate organizations to address some of these challenges. So this is really a call to action for the industry. There are some opportunity areas where CAQH may take the lead, but there are other areas, and I'll talk about this in a second, where other organizations are better positioned to move the industry forward, and we want to recognize that. So the final slide here outlines our 5 key opportunity areas that are included in the report. This non-standardized data and workflows and operations really can challenge successful implementation. And so within these 5 areas, there are specific strategies recommended where the industry could come together and improve the information exchange between plans and providers without compromising the competitive value of the VBP models. So I look forward, and if you're interested in learning more, I would encourage you to register for our webinar on April 10th. Probably by virtue of attending this webinar, you will also receive a copy of the report once it is publicly released. So with that, I'm going to turn it over to Jessica for our first polling question.
Thank you, Erin. So we are going to take a pause before our featured presentation and get some information from you, our audience. So let's launch this poll. We would like to learn a little bit about you and what your role is in VBP in your organization. So option 1, are you in management and oversight? Are you working on contracting? Do you do work on claims adjudication and reconciliation? Are you specifically working on quality measurements, or is it other or none of the above? So let's give this a few more seconds and get some information. And I think this is information that's helpful for us as we are making sure that we have content that is helpful to our audience. So we will go ahead and close the poll and move forward with our presentation. Now I would like to introduce our featured speaker, Aparna Higgins. Aparna is a recognized leader with expertise in payment and delivery system reform, quality measurement, and healthcare analytics, and also has experience in both public and private sector healthcare programs. She was previously a senior executive at America's Health Insurance Plans, or AHIP, where she led her organization's efforts in payment reform, chronic care management, prevention and wellness, healthcare costs, and quality. At AHIP, she also helped establish and successfully led the Core Quality Measures Collaborative in partnership with CMS and other national stakeholder organizations. Prior to AHIP, Aparna worked at Booz Allen Hamilton, where she led research studies for CMS, ASPE, and VA administration, including co-leading the Medicare Hospital Value-Based Purchasing Report to Congress. Aparna, thank you for being here. Go ahead and start whenever you're ready.
All right. Thank you, Jessica. And thank you all for joining the webinar. I'm really looking forward to speaking with all of you today and to provide you an overview with the value-based payment landscape. This slide shows, this next slide shows sort of a word cloud. And I'm sure that a lot of you have seen several of the terms that are on this slide, like shared savings, shared risk, capitation, value-based payment, attribution. So My goal today is to help all of you make some sense out of this word cloud and put some structure around it, talk about, kind of where we are and where we're headed. So the agenda for today's presentation is to first, talk about the rationale. So why value-based purchasing? Spend a little bit of time talking about definitions and a framework to help us organize our thinking around value-based purchasing or VBP. What are some key trends we're seeing in the private sector? What is Medicare doing in the space of value-based purchasing? I'm going to touch briefly on what's happening in the states, and then wrap up with discussing some of the challenges that people are encountering, as well as, what the road ahead is for VBP. So I talked about rationale. So, why VBP? Why not stay with fee-for-service? And in the next few slides, I'm going to discuss the rationale behind the move towards VBP. And I'm sure many of you know why we're headed in this direction, but I think it's helpful to set the context for today. So some of you might have seen this. Recently, CMS released projections for national health expenditures in the U.S. And what you can see from the slide, we've had a very steady and fairly accelerated growth in the rate of spending in this country. And at this rate, we're expected to cross 20% of gross domestic product, which is a measure of the wealth of nations. So we're starting to spend a greater and greater portion of our GDP on healthcare. And I think in addition to spending a greater portion on healthcare, the rate at which healthcare spending is expected to grow is also accelerating. So between 2008 and 2016, we had a roughly 4.4% growth. And that growth rate is set to, increase in the next decade. Compare that with, or contrast that with the expected growth rate in the actual gross domestic product itself, which is the wealth of this country, at 2%. So you have healthcare growing at, expected to grow at a greater than 5% rate, and then you have GDP growing at a 2% rate. So obviously, a greater and greater portion of the wealth of this country is being shifted towards health expenditures. So what that means is we have less to spend on other priorities like infrastructure, like education, and so forth. And there's been some work done. For example, Peter Orszag, who is the former director of the Office of Management Budget, has done some work looking at state spending on education, and had shown that it's been going down, and looked at, sort of postulated that the reason it was going down was because healthcare spending in the states was going up. So it's not just, that we're spending a greater proportion of our GDP on healthcare, but in, this slide shows kind of how U.S. compares to other advanced countries, or what's called as OECD countries. So as you can see, we from this slide, we on a per capita basis, we spend way more than a lot of the European countries, and also Canada, Australia, and New Zealand are on there as well. So we're spending more per capita, and we're also growing at a faster rate in terms of spending compared to the other countries. And all this would be fine because the U.S. is a wealthy country, so you would expect wealthy countries to spend, more on health. But what are we getting for the spending? Are we able to generate a lot of value for what we're spending? Is that really the case? So I thought it would be helpful to take a look at how the U.S. compares to other countries on some key, metrics of population health. So life expectancy of birth, infant mortality, obesity rate, and daily smokers. So as you can see, even though we're spending a lot more than a lot of these other countries, we're not getting as much quality in terms of some of these key metrics, especially as it relates to infant mortality and life expectancy at birth. We're, pretty much at the bottom. So what this translates to is that we're not getting a lot of, value for what we're spending. And then in addition to these sort of cross-country comparisons, there's also data which I haven't included in the slide, but that has been published by the Agency for Healthcare Research and Quality. They put out an annual report looking at the quality of care in the U.S. as well as disparities, and their reports continue to show that there are significant gaps in care that need to be addressed. Yes, we're improving relative to quality, but there are also gaps that need to be addressed. So, next slide, please. So in terms of the rationale, I think the last three slides kind of laid the groundwork for why we would want to move towards value-based purchasing or payment, because we're spending a lot, we're not getting a lot for what we're spending. And then some of the other reasons why we're shifting to value-based payment is also that a good significant chunk of our spending is actually wasteful or going towards inappropriate care. So there was a paper a few years ago by Don Berwick and Hackbart that actually looked at what % of our healthcare spending was going towards wasteful spending or inappropriate care, and they found that about 20% of our spending is actually going towards care that might be not needed, and not just not needed, in some cases may be harmful to the patient. So what this slide shows you is sort of some of the reasons why there's been a paradigm shift and a movement away from fee-for-service towards value-based payment. And the other reason, too, is one of the things that the fee-for-service system has perpetuated is this, siloed care. So there's not enough care coordination among the different care settings and among the care teams that are taking care of the patients, and there's sort of a disintegration in terms of how care is delivered and the way it's siloed, not just across time, but also across, different care settings, what I like to call sort of the space-time continuum. And finally, I think the providers are starting to realize that there's a better way to organize and deliver care that is more meaningful and actually can lead to better outcomes for patients. And so there's a greater level of readiness among the providers to move towards value-based payment. So the next couple of slides, what I'm going to do is sort of talk about some definitions to help level set for today, as well as present a framework that will help us think about, how to organize or thinking about value-based payment. So just in terms of today's presentation, so what is value-based payment? So we've talked about the rationale and why we need it and what are some of the factors behind shifting of the paradigm. So by value-based payment, people typically mean, as the title says, tying payment to value. And the question then becomes, how do you measure value? And typically it's viewed in two dimensions, quality and cost. Now, the primary focus during the past decade, where there's been a lot of activity in value-based payment, has been around, value-based payment to providers. So this is, physicians, hospitals, post-acute care, and so forth. What's emerging now is value-based payment for medical technologies, such as drugs, devices, and so forth. That's still in a very nascent stage. There are a few examples out there of providers and of drug manufacturers and payers entering into contracts, but that's still, evolving. So the focus of today's presentation will primarily be on value-based payments as it relates to providers. Some of you might have heard the term alternative payment models. It's often used synonymously with VBP, especially for providers. And the reason why it's called alternative is because it's unlike traditional fee-for-service, which, as many of you know, had no real links to quality or value. And then you might have also have heard the terminology delivery system reform. And what that means to me is that it's really focused on changes in the way care is delivered. So I talked earlier about wanting to move away from silos to more clinically integrated care. And so that's the primary aim of delivery system reform. And then the question then becomes, how do you structure payment to enable that to happen? Next slide. So what are the goals, or what are we trying to achieve? What's the industry trying to achieve with the move to value-based payment? So I'm sure many of you have heard of the word triple aim, which was a concept that was introduced again by Don Berwick, who was former administrator of CMS. And that the triple aim really referred to better care, which means right care, right setting, right time, lower cost. Obviously, we've seen the data on the cost, and everybody realizes that there's an imperative to reduce the cost of care. And then also, in addition to ensuring better care and lower cost, that we're actually looking to improve the health at the population level. And that's why the third aim, which is healthier people. But more recently, a fourth aim has been added, and that's improving the work life of healthcare providers. So there's a lot of talk right now about clinician burden, and a recent survey that was conducted by Medscape showed that when they surveyed physicians from 27 specialties graded the severity of their burnout on a scale of 1 to 7, 1 being that there's no burnout, and 7 being they want to leave the profession. And all but one specialty selected a 4 or higher in terms of burnout. So part of what VBP is trying to do is also reduce the burden on the physician and actually make the practice of medicine more enjoyable. The joy of APMs, as a colleague of mine once described it. So addressing physician burnout has been added to the triple aim. So this slide, I wanted to spend a little bit of time talking to you about what the components are. And I'm sure, again, many of you have seen some of the terminology, and I think it's helpful to just kind of revisit it and set, do a level set for the purposes of today's presentation. So as we see it, the main components of alternative payment models or value-based payment are first, obviously, the payment piece, which is the incentive. And that typically involves using some non-fee-for-service method of payment. Examples include pay for performance. You might have heard the term care management fee, but which is kind of a per member per month fee that's paid to help with care coordination. Shared savings, where a payer and a provider might enter into a contract with a set cost target, and if the cost for that particular performance year is below the target, then the provider gets to share in the savings. Shared risk takes it one sort of level further, and so you have a target. If you generate savings, you get to keep it. If you're over the target, then you have to share some of the losses with the payer, and then all the way to partial or what many of you know as full capitation. The other sort of most important component is the quality measurement piece, and this is where I think the models of today are very different from the managed care of the 90s. I think we all remember the backlash that emerged. And so quality measurement and performance measurement is a key component of the value-based payment models that are being designed and implemented today. So they really help assess provider performance. And you have measures of both clinical quality, and I've given an example here, A1C control for diabetics, but there are a lot of other quality measures that are in use, but also looking at patient experience with care, which are typically survey-based measures. And more recently, there's been a much greater interest in moving towards what people are calling patient-reported outcomes. The third component is the patient attribution. So these are really methods or rules to assign responsibility or accountability for quality and costs associated with the patient population to providers. And there's sort of three different rules that are primarily in play. One is prospective attribution, where a provider knows in advance the population of patients for whom he or she is going to be responsible. A retrospective attribution model, where the provider knows the population that's attributed to them sort of after the fact, at the end of the performance period. They're delivering care during, so let's say, a calendar year, and at the end of the period, based on some rules, it's decided that you're responsible for the performance of this population of patients. And then a slight variation on the prospective attribution, which is concurrent attribution, where providers know ahead of time, here's the list of patients for whom I'm responsible, but also payers recognize that there's churn over time, members enroll and disenroll, and so that list, for example, is updated quarterly to account for patient churn. Financial benchmarking is another component, and here this is where specific spending targets might be established between the payer and provider that are part of the contract. These targets typically tend to be based on the historical spending experience of that particular provider's practice. Initially, when a provider is entering into a contract, those financial benchmarks are based on their historical experience, but sometimes they can be a mix of a provider's historical spending experience combined with, what the regional cost trends are, for example. And might also include, as in some models, sort of a national trend. So it could be a blend between the provider's experience, the regional cost trend, and the national cost trend. So these are sort of the key, components of a value-based model, and specifically how the various parameters get established in each of these components is really decided programmatically in the case of Medicare by the Medicare program, or in the case of health plans, it's really decided and negotiated between the plan and the provider. Next slide. So given the plethora of models, so we have the definition, the components, and we all know that there's a lot of experimentation going on in the field. So, how does one make sense of all these models? So what you see on this slide is a framework that is being used to help organize or thinking about value-based payment or alternative payment models. It kind of shows you the spectrum of the payment models that are currently in play. This framework was developed by the Healthcare Payment Learning and Action Network, commonly referred to as the LAN. It's a multi-stakeholder collaboration, and it's seeking to accelerate adoption of alternative payment models through alignment of public and private components of these payment models. but also to help with the diffusion of best practices. The LAND framework really categorizes the APM models into 4 categories, and then each of these major categories are subcategories underneath them. So you can see fee-for-service on the left-hand side. The category 2 payments are slight modifications of fee-for-service. They include things like pay-for-performance, which I'm sure many of you are familiar with, was a huge deal in the 90s. Category 3, which looks at these kinds of value-based payments that only have a shared savings component to it, which sometimes is referred to as upside risk only. And then a subcategory 3B that includes shared savings and shared risk. And then all the way to category 4, which are population-based payments. So this includes things like condition-specific, or what you might call partial capitation, all the way to global capitation or global budget. And then at the very end of that same spectrum is also integrated finance and delivery systems, where both the financing and the delivery all together, I'll just draw, Kaiser Permanente being a good example of category 4C. Next slide, please. So in addition to putting out the framework, the LAN was also trying to answer the question, where are we in this journey towards, VBP, and how far have we progressed? So for the past 2 years, they've been undertaking a measurement effort to look at the nation's progress towards adoption of value-based payments. What you see here are the most recent data that they released at the end of last year. It measures adoption of value-based payments for calendar year 2016. And as you can see, less than half the payments are still in what are called legacy payments, which is fee-for-service. You have, a little bit over a quarter in category 2, which is like the pay-for-performance, care management fee type payments. And then the 3 and 4, which is where I think everybody's trying to move to, now account for approximately 30%. So we're headed in the right direction, but obviously there's still a long way to go. And I just want to emphasize that these data reflect both plans that reported to the LAN in terms of where they are in their value-based payment journey, but also includes, the Medicare fee-for-service program as well. Next slide. So I'm going to switch gears a little bit. So I've kind of set the stage talking to you about definition, framework, kind of where we are relative to adoption of value-based payment as a country, and then talk to you a little bit about trends in the private sector. The first thing I thought I would do was actually talk to you about what are some of the key trends in the private sector. First, there has been a significant growth in value-based payment efforts in the private sector. A number of these efforts started at the beginning of 2010, 2011, and they're continuing. And then some of the other trends that we are seeing are an increased focus on reducing wasteful expenditure and inappropriate utilization. I talked earlier about the fact that about 20% of the spending is inappropriate or wasteful. So obviously, and not surprisingly, there's a big focus on that. And a campaign such as the Choosing Wisely campaign, which was launched by the ABIM Foundation, have really helped shed a light on this issue and increased awareness of this issue around inappropriate use. I think, and the other trend that we're seeing in the private sector too is attention to minimizing the impact of price. So cost is really price times quantity. So it's not just enough to tackle utilization. If you want to tackle cost, you also have to tackle the price. So there's a lot of attention in terms of where referrals are being made, what the appropriate, what I call sites of service are. Is it better to have the same service performed in a hospital outpatient department versus a physician office? So again, a lot of attention being paid to, price. And then again, I talked about this a little bit earlier in terms of the components of value-based purchasing, attribution, benchmarking, quality measurement, and incentive. And what is certainly true in the private sector is that a number of these initiatives and these contracts are being customized to meet the providers where they are in terms of provider readiness. So you have to realize the providers obviously have been practicing in a fee-for-service environment for a very long time, and asking them to move into this new world of value-based payment requires a whole new set of skills and capabilities that they will need to acquire over time. So tailoring these contracts to meet the providers where they are in terms of how ready they are to move into these is a critical component of these private sector contracts. Next slide. So I want to spend a little bit of time talking to you about the kinds of models that are being implemented in the private sector. So I'm going to put them into sort of two categories. One is the population health models, which are mostly primary care focused, and then the specialty care models, which are referred to as bundle payments or episode-based payments. So on the population health side, we have what many of you might be familiar with, which is the patient-centered medical home. I've included definition on the right-hand side of the slide that came from AAFP, but essentially it's a redesigned approach to care delivery within the primary care setting, as well, and it's really designed to promote care coordination and ensure that care for the patient is seamless across settings, and giving a lot of the responsibility and management of the patient to the primary care provider. The Accountable Care Organization, or ACOs, as many of you would have heard, is a similar concept. Again, it's a population-based model where providers take on, in most cases, responsibility for total cost of care for a patient population. Obviously, quality, again, is a major component to these contracts. But it's really focused on the care of the whole patient. So you want to contrast that with some of the specialty care models, which are mostly bundle payments or episode-based payments that focus on specific clinical conditions. For example, there are a number of health plans that have implemented bundle payments for oncology care focused on particular cancers like breast cancer, colon cancer, and so forth. So ones that are more commonly occurring or more prevalent. Orthopedic surgery is another key example of a bundle payment where it's easy to define an episode. There's a preoperative stage. There's the actual surgery and a post-op, so it's a defined set of services, and the plan, the provider, or the payer and the provider can then enter into a contract around those defined set of services. Maternity care is another area where it's pretty well defined and lends itself well to episodes-based payment or case rates. And then cardiac surgery in some cases have also been subject to these kinds of bundle payments. So these are the kinds of models that we're seeing in the private sector. Next slide. So I know we saw the APM measurement effort from the LAN, and there are no independent estimates of where are we relative to value-based payments in the private sector. The data that I showed you combines Medicare data and private sector data, so it's hard to parse out where the plans are relative to Medicare. But I wanted to include this slide. Came out of an article that was published in Health Affairs blog. It kind of shows you the growth in ACOs across payers, and as you can see, there's been pretty rapid growth in terms of ACOs in the commercial sector, and so it gives you a sense for how pervasive value-based payment is becoming or has become in the private sector. And this is, remember, it's just one kind of model that's being implemented. There are a number of other types of value-based payment models in the specialty care area, for example, that's obviously not captured in this slide. Next slide. So I talked to you a little bit about how one of the key trends we're seeing in the private sector is how plans tailor their contracts to meet the providers where they are, and they look at provider readiness. So exactly what do plans look at in sort of assessing provider readiness? So what this slide shows is some of the factors or criteria that plans take into account when assessing how ready a provider is to enter into these value-based payment contracts. So one is looking for demonstrated experience. So whether they've achieved some level of certification, have they been participating in demonstrations with CMS? Have they had an experience with contracted HMO arrangements in the past? Or are they involved in collaborative learning opportunities? They also look for health IT capabilities because data and information, as you'll see in the next slide, is an important factor in success in all of these models. So are they using EHRs and registries? Are they meeting, for example, meaningful use requirements? And then finally, they're also looking to see if the providers have made a commitment to care delivery transformation, because that's, again, an integral part, and that's why payment is being changed to enable that care delivery transformation. So looking at in terms of, are there documented processes? Do they have 24/7 availability of providers to their patients? Do they have detailed action plans and how they might approach quality improvement, for example? So these are some of the factors that we found in a study that we did that health plans look at to assess provider readiness. Next slide, please. And then the other thing that private payers are recognizing too is that for providers, this is a journey that takes them from a fee-for-service environment to a different kind of an environment, and therefore it's important for them to for them to be successful. They need to have certain skills and capabilities. And historically, plans have been really engaged in population health management. A number of providers are new to this, and so plans are increasingly helping providers with a number of these elements in order to help providers be successful in these contracts. So they're sharing a lot of data, and that includes both raw data in terms of claims data sets, but also in terms of reports and information that is actually actionable. Things like predictive analytic reports that identifies patients that might be at high risk for acute exacerbation of disease, and therefore may benefit from early interventions, might be one example. Benchmarking reports to show where a particular provider might be relative to other providers and their peers in terms of quality and cost, where some of the gaps in care are. So lists of patients, for example, who might be missing their preventive screenings and might need to come in for a visit and get their screening done. And the other area where there's a lot of support from the payers is also around care management. So care transitions and making sure that care is coordinated and seamless across settings is a key element, and therefore, plans are able to deploy their care management nurses to help the provider practices in these new models, manage their patients and manage those care transitions. And what we're seeing is that initially, you can have a plan case manager actually embedded in the practice, helping with those care transitions. And as the provider gets more experience and becomes more mature in these models, they take on the care management role from the plan. And finally, payers are also providing a lot of consultative support in terms of getting these providers ready for these contracts and giving staff resources. Next slide. So the question is, what has all this experimentation on the private side, resulted in? What have we achieved? So I wanted to show sort of two slides in terms of some of the results that we're seeing. So in this particular slide, I wanted to highlight a particular contract, the alternative quality contract that was implemented by Blue Cross Blue Shield of Massachusetts, which many people view as a poster child for this value-based payment model. It was originally implemented in 2009. It was a population-based model that included both a global budget, but also had additional incentives for achievement of quality performance. And it currently covers about 90% of the physicians and hospitals in the Blue Cross Blue Shield of Massachusetts HMO provider network. And in addition to being one of the pioneering and long-standing sort of poster child examples of value-based payment models in the private sector, Blue Cross Blue Shield of Massachusetts also undertook an independent evaluation that was done by academic researchers at Harvard. And what these researchers have shown is that there have been significant improvements in quality, both in the preventive care measures as well as management of chronic conditions for the patients who are under these contracts or treated by providers under these contracts, and that achievements in quality are better than national average. But there have also been significant cost savings. So in 2009, the savings in medical spending was about 2.4%, and in 2012 was up to 10%. And they actually did sort of a comparison between the population that was in these contracts with a control group that wasn't in these kinds of models. So they were actually able to prove causality, that the implementation of the alternative quality contract led to better quality outcomes and also resulted in significant cost savings. Next slide. So these are a summary of some results based on some select national plans that make their results public. I wanted to give you a flavor of some of the self-reported data on both quality as well as cost savings from these plans. So as you can see, there's a wide range in terms of some of the improvements in quality, and I actually labeled reduction in ED visits and inpatient admits, even though they are measures of utilization. I call them quality because I think from a patient standpoint, it is better for somebody to not go to the ED or not be admitted to the hospital. It's actually a better outcome. And so you see some wide ranges here, all the way from 7% up to 60% reductions. Same thing for the inpatient admits. And then again, in terms of some standard measures, such as the HEDIS quality of care measures, they're reporting higher scores for these populations treated by providers and value-based payment models. One thing I will note is that, these are self-reported data, and also that the actual way these measures are calculated may not be exactly the same across the plan. So I just wanted you to keep that in mind as you're looking at some of these results. And then also, several of these plans are reporting significant, cost savings, both in terms of total cost of care, but also in terms of savings generated by specific value-based payment models focused on specific conditions such as, or procedures like spine surgery or joint surgery. So these are not based on independent evaluations, like the previous slide, but at least gives you some sense of some of the effects that we're seeing in the field relative to both improvements in quality and reductions in cost. Next slide. So I'm going to switch gears and talk a little bit about what we're seeing relative to value-based purchasing in Medicare. What this slide shows, I just wanted to give you a flavor for the different types of models that are being implemented by the Center for Medicare and Medicaid Innovation. So I would sort of classify, Medicare's implementation of these models into two buckets. One is all of the demonstrations that have been put forth through CMMI, and that's essentially emerged from the Affordable Care Act and raised provisions in the Affordable Care Act. And then I also want to talk a little bit about what many of you know as MACRA, and I'm going to spend a little bit of time on that. So this slide gives you a flavor of all the different types of categories and different kinds of models that are in play. And, in the accountable care, you have examples like the Medicare Shared Savings Program, bundled payment. You have things like the comprehensive joint replacement value-based purchasing model that's being implemented. Primary care, you have things like the Comprehensive Primary Care Plus, and I know in a prior webinar you had somebody from CMMI present on that. You have models being put into place that are trying to get to better financial alignment for dually eligible beneficiaries. So there's a variety of models that are being implemented by CMMI that are being, tested. Next slide. And I also wanted to sort of give you a sense for within some of these specific categories, the breadth and the scope of experimentation. So what this slide shows you is just a number of CMMI initiatives that are being focused on or have focused on primary care. And they vary from single-payer models that were purely Medicare fee-for-service to multi-payer models where Medicare either partnered with other payers and also partnered with ongoing state-based initiatives to test how these alternative payment delivery reforms might be able to improve quality and reduce costs. But I think this gives you a flavor and a sense for the level and scope of experimentation that's happening because of Medicare. Next slide. Just in terms of some of the ongoing activity with CMMI models, again, similar to the private sector, models fall into two categories: population-based models, which are like the Shared Savings Program, which is an ACO model, the Comprehensive Primary Care Plus, which you've all heard from before, the Next Generation ACO model, which is a similar to the MSSP program, except it has sort of a higher risk, higher reward structure compared to MSSP program, as well as has some waivers that have been put into place. And then there's the specialty models around oncology care. I talked about the joint replacement, the bundled payments, and then the ESRD models, all focused on, very specific conditions or procedures. So in some sense, parallel to what we see in the private sector. And some of these models, like for example, the oncology care model actually involves it's a multi-payer model where CMS is partnering with about 14 payers in the implementation of the model. Next slide. In addition to all the efforts of CMMI, as you all know, MACRA was signed into law in April 2015. It replaces the Sustainable Growth Rate, and it really has sort of two programs. One is the Merit-Based Incentive Payment System, or MIPS, which offers potential bonuses or penalties based on how providers perform on quality, resource use, meaningful use requirements, as well as fulfilling certain clinical practice improvement activities. Obviously, this is what is in statute. We're in year 2 of rulemaking, actually going into year 3 of the program. And then in addition to MIPS, there is another pathway for physicians to earn bonuses, which is the alternative payment model track. And in order to earn a bonus, physicians have to meet certain requirements, which I'm not going to read through all of them. They're on the side. And there are some of the models that are that have been implemented by CMMI that actually would help physicians qualify to earn a bonus through the alternative payment model track, such as being part of the oncology care model or the next-gen ACO model, for example. Again, the rules that have been issued by CMS, actually go into the parameters that physicians need to meet in order to earn the bonuses. I'm not going to go into that today. We don't have time for that, but this is just to give you a sense for, in terms of VBP, there are the demonstrations and tests that are being run through CMMI, but then also some of that intersects with what is required under statute through MACRA. Slide. So then the question is, what is, all this experimentation in Medicare led to? Are Medicare models delivering value? So CMS actually undertakes independent evaluations of their various, model demonstrations. And they make all of their results publicly available. It's on the Innovation Center website for those of you who are interested. And so I just wanted to provide you a flavor of some of the results that are being observed. So if you looked at the evaluations of the primary care initiatives, that was the table I showed you with all the different primary care demonstrations that CMS has run to date. What the findings show is that for 4 out of the 6 initiatives, there weren't really significant differences between the patients who were treated in these initiatives versus ones who were not, which would be the control group, relative to some core metrics around ED visits, Medicare spending, hospital admissions, and 30-day readmissions. There were some mixed results, obviously, in some cases. For the high-risk population as well as beneficiaries who qualified for Medicare based on disabilities, there were 4 initiatives that lead to decreased Medicare spending. The outcomes in terms of some of the other programs like the Shared Savings Program, the Pioneer ACO, the Next Generation ACO, as well as the ESRD model are a little bit more positive. And I've sort of outlined some of the key outcomes from these programs on the right-hand side of that table. So the MSSP program, for example, we found that 56%, saved money relative to their benchmark. For the Pioneer ACO, 6 of 8 Pioneer ACOs generated savings. There were some pretty impressive results relative to the comprehensive ESRD model that was being reported out of Medicare, both in terms of cost savings, but also in terms of improvements in quality. So the needle is moving in the right direction based on the Medicare models as well, similar to what we saw on the private sector side. Next slide. I want to touch upon briefly the state efforts in VBP. We won't have a lot of time to go in depth today, but I thought it would be incomplete if we didn't at least give a very high-level overview of what's happening. So as you know, many of you know, many of the states actually have managed care contracts. And in these states with managed care contracts, states are either using withhold or pay for performance with their managed care contracts. That's one approach, if you think about it, to getting to value. In many of these states, there's also an increasing integration of physical and mental or behavioral health. So in the old days, they used to carve out mental health, but in many states, they're carving it back in so that you can take care of the whole patient. And then we're also seeing that in some of these states, there are multi-payer initiatives. So examples include Arkansas, Wisconsin, New York, Michigan, and Vermont, where you have sort of multi-payer initiatives. States are also paying a lot of attention to social determinants of health, and they're doing that in a variety of ways, in terms of building better relationships with community-based organizations. For example, in Massachusetts, they plan to measure ACOs on whether ACOs are doing social service screenings and so forth. So there's a lot of attention being paid to social determinants of health. And then, we expect to see increasing activity in the states relative to design and implementation of value-based payment contracts. In 2017, 40 states had one or more delivery of payment reform initiatives in the form of ACOs, PCMH, and so forth. And we anticipate that this activity will increase in the future. Next slide. So that was a very quick overview of what's happening in the states. So I do want to spend the last few minutes talking about what the key challenges are, as well as where we're headed Next slide, please. So in terms of overall challenges in the transition to VBP, I touched upon this a little bit earlier. So what we need is better evidence. I think, there are a number of independent evaluations that are occurring, especially as it relates to Medicare, but I think we need more of them. And what we need to understand better is what is the optimal mix of VBP components, incentives, attribution, data and information that can lead to, a better outcome both in terms of quality as well as cost and help us achieve the AAA. Data and infrastructure, as many of you know, is another huge area, which is a problem. Interoperability continues to be an issue, and I think that claims data are not enough, but, registries are expensive. So the question really becomes, how do we make data more interoperable, but also how do we make data more liquid? And I think the current administration has made some recent announcements that is going to help in this space. We also need better payer alignment on the key components of value-based payments. So right now, providers who have contracts with different payers, have to live with a different set of rules for each payer. And so for them, it becomes very hard to manage a practice when they have different quality measures, different attribution rules, different financial benchmarks and so forth, and different data feeds coming into their practice. So it becomes very complex for them to manage those kinds of contracts. I haven't talked at all today about the role of the patient. I think there's more work that needs to be done in terms of thinking about how does benefit design and patient activation and engagement fit into these value-based models. There's a lot of work being done in value-based insurance design, but I don't think there's an effective model yet of incorporating the provider side innovations with the consumer or patient side innovations. I've talked already about addressing social determinants of health. And lastly, I want to come back to this idea of prices. And I put that, it's the price is stupid, which is actually the name of the title for an article that was published by Uwe Reinhardt in 2003, where essentially the reason why healthcare the U.S. spends more on healthcare is not purely because of utilization. A lot of it is driven by price. So the price of healthcare in the U.S. is much higher compared to other countries. And therefore, if we don't really tackle prices, I think then, we're not going to really be able to get our hands around healthcare costs. And then I should say it's still the price is stupid because more recently, reports by the Healthcare Cost Institute and the Institute for Health Evaluation Metrics that published a paper in JAMA where, their data have shown that prices are still an issue and need to be, tackled if we are to get costs under control. Next slide. So where are we headed? So the roads for Medicare. So this slide is actually based on a recent speech that the new Secretary of HHS gave to the Federation of American Hospitals, where he clearly outlined value-based transformation as a top priority for the agency, and within that sort of laid out particular areas of emphasis. So the first is to give patients and consumers greater control of their health data. And so they've launched Blue Button 2.0, which will help release Medicare data to Medicare beneficiaries, so data actually become liquid, and they're encouraging other payers to do the same. And then he also emphasized price transparency, the importance of having and knowing what the prices of various services are in healthcare. There's work that has already occurred in this area, but more work obviously needs to happen. He talked a lot about bolder experimentation in Medicare, going beyond, for example, the joint replacement bundle. And so these are, sort of the areas of emphasis that, he's laid out relative to what's coming in terms of the Medicare program. And then I think I also want to mention that there's a lot of talk within the agency about regulatory relief and making sure that whatever regulations are in place, make sense and protect the beneficiary, but don't inhibit providers from undertaking or implementing new innovations. And he gave ride sharing as an example, where currently there are actually limits on how many free ride shares a provider can give a patient, when the most important thing is to get your patient to the appointment. And so, those are the kinds of things I would imagine the agency would be looking at going forward. Next slide. And where are we headed relative to all payers? I anticipate there will be ongoing experimentation and implementation of value-based payment models, but I think there's going to be a shift from quantity to quality. So can we implement, better models, more successful, models that can help providers be successful and lead to better outcomes? We also I think there'll be a greater focus on multi-payer alignment, building off of the experience of existing multi-payer efforts, and again, aligning on those, key components of value-based payment that I talked about earlier. From the state standpoint, I think there's 13 states in 2017 that set a target percentage of MCO provider payments that must be in alternative payment models, and 2018 it's expected that 9 more states will follow. And then I think there'll be more work in terms of linking benefit design to value-based payments, so integrating the patient better into these models. And then so far there's been sort of, again, silos. There's been population health models and specialty models. I think more work will occur around trying to integrate specialty care better with primary care is another area that I see that we should watch out for in the future. So with that, I will stop and turn it back to Jessica. I know that was a lot, but Jessica?
Thank you so much, Aparna. That was really, really helpful. I know I learned a lot listening to your presentation. So what we're going to do next is we're going to take a quick polling question. And if you do have questions, start thinking about them, because we do have time to take a few of your questions. So the second polling question, we'd like to hear from you. What would you like to see as a topic of a webinar in the future? Would you like to hear more about what CMMI is doing? I know we did one earlier on their Primary Care Plus program, but do you want to hear more there? Do you want to hear more about what the states are doing, Medicaid, but also other state initiatives? Do you want to hear about interoperability? Or are there other topics that you are interested in? So let's go ahead, take a few seconds, and maybe give it 2 or 3 more seconds, and then we can share results with the audience. So let's go ahead and share the results. So it looks like interoperability is top of mind for most of you, so we will definitely keep that in mind. And then I think there is a pretty strong group that are interested in the CMMI work as well as the state work. And for those of you who clicked other, I look forward to seeing what your ideas are for future webinars. So we do have time to take a few questions, so let's move on to that. Okay. So we've got a few questions coming in. The first question's for Erin. So what type of candidates are you looking at for the VBP advisory group?
Good question. So we envision this advisory group being a small group of advisors representing the various stakeholders involved in value-based payments. At this level, we're really looking for decision makers within the organization, those that are overseeing the implementation and operations of value-based payment. As we move into the detailed work, so that advisory group is going to kind of select the strategies that CORE will pursue in this area, so the options that are outlined in the report. And then we'll be forming tiger teams based on the particular topic that has been selected by the advisory group, because the people that really know more information about kind of the day-to-day challenges are those that are really like living and breathing it on a daily basis. So those groups will probably have more targeted individuals on them. That's probably a good overview.
Thank you so much. The next question, I think it's kind of a reading the tea leaves question for Aparna. Will FFS eventually go away?
Well, there is a little bit of reading the tea leaves, but I think we should probably expect that based on what I'm seeing in the field. I think that's the goal, is to move away from fee-for-service. It might still be potentially an accounting system sort of in the back end just to keep track of transactions, perhaps. But I think as a form of payment, I certainly, I think the push is to move away from fee-for-service and turn to value. How quickly we get there remains to be seen, I think. I think we've made a lot of progress, but there's still a lot of challenges that we would need to overcome.
And then one last question for you, Aparna. Do providers want to transition to VBP?
Oh, I think so. I mean, just based on my experience talking with various provider groups, because they see this really as a way to get to better patient care, and I think that's why they went into medicine to begin with, and so they really see this as an opportunity to do that. Obviously, they're also wanting to be successful in their practice and making sure that they have the right supports, and I think that's where the payers, are helping and can continue to help.
Thank you very much. So we are out of time. In the next slide, I'd like to share the next BBP webinars in the series so far. On the top of the slide are the webinars we've already done, and at the bottom of the slide is the upcoming webinar in April that Aaron already referenced, and you can register by clicking that hyperlink where it says here. And then on the next slide is some information on how to reach us. If you do have questions and you just didn't have a chance to submit them today, feel free to contact us at that email and we will get you an answer. And then the last thing is, I want to remind all of you, we will be sending the slides and recording to you. So this was a lot of information. There's an opportunity for you to review the slides or listen to the recording if that would be helpful. Have a great afternoon.